Welcome to our internal medicine series on pleural effusion. This video covers a resident's approach to this common clinical problem, following a patient from the initial bedside assessment to the final interpretation of pleural fluid and treatment. Let's meet our patient, a 64-year-old man presenting with 6 days of fever and a productive cough. He reports 2 days of sharp pleuritic chest pain and increasing dyspnea on exertion. Every decision we make will be guided by this story. Our roadmap for this video is straightforward. We will define and classify pleural effusions, discuss common causes, walk through the diagnostic workup, interpret pleural fluid findings, and explore management strategies for the parapneumonic spectrum. The patient's history is revealing. His symptoms evolved over 6 days, culminating in his current dyspnea. Notably, he denies hemoptysis, leg swelling, or orthopnea. These key negatives help us move away from purely cardiac causes and toward infectious ones. Reviewing his background, we see a history of hypertension and diabetes, along with a significant smoking history. The absence of travel, TB exposure, or asbestos helps narrow the differential. We ask these questions to properly assess risks for infection or malignancy. On physical exam, he is febrile and tachypneic. Over the right lung base, we find the classic triad: dullness to percussion, decreased breath sounds, and reduced tactile fremitus. This pattern is the hallmark of fluid layering within the pleural space. A pleural effusion is simply an abnormal collection of fluid in the pleural space. It occurs when fluid formation outpaces absorption. Mechanistically, every effusion falls into one of two buckets: a transudate, involving systemic pressure issues, or an exudate, involving a local leak. Pleural effusions are very common, affecting over 1.5 million people annually. Because an effusion is a sign and not a diagnosis, our clinical duty is to determine the underlying cause, whether it be heart failure, infection, malignancy, or a pulmonary embolism. At the molecular level, this is a matter of Starling forces. Transudates arise from systemic factors like increased hydrostatic or decreased oncotic pressure, leaving the pleural membrane intact. Exudates, conversely, result from local inflammation that increases capillary permeability or blocks lymphatic drainage. Transudates are often caused by systemic conditions. Heart failure is the most frequent cause, typically resulting in bilateral effusions. Cirrhosis can lead to hepatic hydrothorax, while nephrotic syndrome causes low oncotic pressure. Constrictive pericarditis and myxedema are less common systemic etiologies. Exudates involve local pathology. Parapneumonic effusions, caused by adjacent infection, are the most common in this category. Malignancy, pulmonary embolism, and inflammatory conditions like pancreatitis or collagen vascular diseases are also major causes of exudative pleural fluid. Clinically, patients may present with the classic trio of dyspnea, pleuritic chest pain, and cough, though many are asymptomatic. The key is to evaluate the effusion in the context of the patient's other symptoms, such as fever, edema, or weight loss. Diagnostic imaging begins with an upright chest X-ray. Lateral decubitus views can confirm free-flowing fluid, while ultrasound is invaluable for small or loculated collections and for procedural guidance. CT scans are reserved for complex cases or when malignancy is suspected. A diagnostic thoracentesis should be performed on any new significant effusion. It is a safe procedure when guided by ultrasound. While complications like pneumothorax or bleeding can occur, they are infrequent with proper technique. Post-procedural imaging is not required routinely. Finally, when sending pleural fluid for analysis, always order protein, LDH, glucose, a cell count with differential, and microbiologic studies. Additional tests like ADA, amylase, or triglycerides should be sent based on specific clinical suspicion to help narrow the diagnosis. Now we use Light's criteria to distinguish between transudates and exudates. The fluid is an exudate if it meets any one of 3 criteria: a protein ratio greater than 0.5, an LDH ratio greater than 0.6, or an LDH level over 2/3 the upper limit of normal serum. Meeting even one of these qualifies as an exudate. While Light's criteria are highly sensitive, they can sometimes overcall exudates. For example, aggressive diuresis and heart failure can concentrate fluid, creating a pseudo-exudate. In cases where the story suggests a transudate, but the labs indicate an exudate, measuring the pleural cholesterol can help clarify the diagnosis. Beyond the basic classification, specific markers provide critical clues. Glucose below 60 suggests infection, malignancy, or rheumatoid disease. A low pH in a parapneumonic effusion is a major red flag indicating the need for a drain. Cell counts also guide us. Neutrophils suggest acute processes, while lymphocytes point toward tuberculosis or cancer. Other specialized tests help identify rare causes. Triglycerides over 110 milligrams per deciliter indicate a chylothorax. A pleural-to-blood hematocrit ratio greater than 0.5 confirms a hemothorax. Matching these specific findings to your patient's presentation helps narrow the diagnosis significantly. Pattern recognition is a powerful tool. By matching your patient's profile to the clinical row, such as heart failure with high NT-proBNP or TB with high ADA, you can often narrow the diagnosis quickly. It simplifies the complexity of pleural diseases into actionable patterns. The parapneumonic spectrum is the most vital decision-making framework in the clinic. An uncomplicated effusion is sterile and treated with antibiotics alone. A complicated one is actively infected, evidenced by low pH, low glucose or positive cultures, and mandates drainage. Empyema, which is frank pus, requires definitive drainage. Returning to our patient, his fluid is cloudy, and the labs confirm an exudate. With a low pH, low glucose, and gram-positive cocci identified, it is a complicated parapneumonic effusion. This confirms he will not resolve on antibiotics alone. He requires urgent drainage. Management for transudates is always about treating the underlying systemic cause. In heart failure, diuresis usually resolves the effusion quickly. For hepatic hydrothorax, we manage sodium and fluids and consider tips, but we strictly avoid chest tubes, which can be harmful and ineffective. For complicated parapneumonic effusions, we escalate care. If initial antibiotics and a chest tube are insufficient, we may introduce intrapleural fibrinolytic therapy using TPA and DNase. Should these measures fail, a VATS decortication may be necessary to clear the pleural space. Special cases like malignant or tuberculous effusions require targeted management. Malignant effusions often need palliative drainage or pleurodesis. Tuberculous effusions are treated with anti-TB therapy. Chylothorax requires addressing the underlying obstruction and dietary management, while hemothorax needs tube drainage and sometimes surgery. Avoid common pitfalls. Tap parapneumonic effusions early before they organize. Be wary of pseudo-exudates in heart failure. Don't drain too much fluid too quickly to prevent pulmonary edema, and never ignore pH and glucose, as they are crucial indicators for drainage. In summary, our patient receives intravenous antibiotics and a chest tube to clear the complicated infection. We will monitor his output and repeat imaging to ensure the lung re-expands fully. This systematic approach ensures we manage the specific clinical needs of his condition. Thank you for watching this guide to pleural effusion. We hope this framework helps you at the bedside. For more, please click the link on the screen for the next related video and see the description for full references. We'll see you next time.